All right, welcome back to the deep dive. Today, we're on a pretty important mission. We're taking all that dense, high stakes material, specifically pediatric ENT content, and turning it into, well, a clinical defense system for you.
Yeah, that's a good way to put it.
We know you have to get past just memorizing facts. The goal is to really embed this stuff for, that high level clinical reasoning you need on the floor and for exams.
Exactly. The goal here is to create a kind of blueprint for knowledge that actually sticks.
Yeah.
We're not just going to read slides. We're digging into the core truths from those slides, your key points, and I think most importantly, the traps that are hidden in all those practice questions.
Okay, so you have this five-pillar system for that, right?
That's right. For any disorder, you have to see it through 5 lenses. 1, the mechanism or the patho, what's actually going wrong. 2, the absolute hallmark symptoms you can't miss. 3, management, both farm and non-farm.
Okay.
4, your priority nursing actions, like what do you do right now?
Right.
And finally, number 5, the big one, the red flags and those notorious NCLEX traps.
And to make this all manageable, because it's a ton of information, we've broken it down into 3 logical clusters, sort of a head-to-toe approach, right?
Yep, we're starting at the top.
Mm-hmm.
Cluster 1 is all about ocular and visual health. We'll get into developmental issues, infections that can steal sight, and even some pediatric oncology.
Then we move over to the ears.
Cluster 2, auditory and otic disorders. This one is really heavy on the unique anatomy of a child's ear, which drives so many problems like chronic infections and hearing issues.
And to wrap it up, Cluster 3 covers the upper airway and throat disorders. I'm guessing this is all about breathing, bleeding, and staying hydrated.
You got it. It's about keeping the airway open, making sure the kid isn't getting dehydrated, and spotting those really subtle signs of bleeding after surgery. So, yeah, these clusters give us a map. But the real power is in the details we're about to get into.
Perfect. Let's not waste any time then. Let's jump right into Cluster 1, ocular and visual health. So sight. It seems so fundamental, but it's also incredibly fragile in kids. I think that's the big idea for this first cluster, isn't it? Ocular and visual health.
It is. The unifying idea is vulnerability. A child's sight is constantly under threat from infections, from trauma, from things that just don't develop right. And for us as clinicians, the only defense is to act fast, be specific, and sometimes be pretty aggressive to stop permanent vision loss.
That urgency is something you really feel, especially in the NICU or on a PED's floor. So where do we even start with the causes? Is it mostly stuff that happens at birth?
A lot of it starts right there. The must-know causes are those perinatal and postnatal infections. We're talking gonorrhea, chlamydia, rubella, syphilis, toxoplasmosis. These can be just devastating if they're not caught.
Which really puts the focus on prevention, right? This is about good prenatal care, making sure mom's immunized against rubella, things like that.
Absolutely. And that leads to a really crucial point, is why we have a standard practice of universal prophylaxis. All newborns get those prophylactic azithromycin eye drops right after birth.
And what if there's an active infection?
Well, that's where the assessment is key. If mom has active herpes simplex virus lesions, for example, a C-section isn't optional. It's mandatory to prevent the baby from getting a blinding ocular or even systemic infection during delivery.
Okay, that makes sense. So beyond infection, there's a complication that's kind of heartbreaking because it's linked to the care we provide. I'm talking about retinopathy of prematurity, or ROP.
Yeah, ROP. This isn't random. It has a very clear mechanism, and it's tied directly to our life-saving technology.
So it's an iatrogenic injury, something we cause.
In a way, yes. It's from too much oxygen exposure in these incredibly vulnerable preemies. You have to picture it. The retinal blood vessels in a premature infant are, well, they're not finished growing yet. So when we give them high concentrations of oxygen to help them breathe, their body senses all this extra O2 hyperoxia, and the existing vessels, they actually constrict and start to regress.
And that regression is the problem, I assume. The retina still needs that blood supply.
Precisely. So after that initial high oxygen phase, we wean the baby off, and now they're in a state of relative hypoxia. The immature retina is starved, and it tries to compensate by growing all these new, disorganized, fragile blood vessels.
Oh, neovascularization.
Exactly. And these new vessels are terrible. They're leaky, they bleed easily, and this is the critical part, they pull on the retina. That pulling causes scarring and eventually retinal detachment and blindness.
So the risk factors then. It's a specific recipe for disaster we need to know.
It's a triple threat. You've got very low gestational age, we're talking around 28 weeks or less, combined with a low birth weight, usually under 1,600 grams, and then you add prolonged high-flow oxygen therapy.
So the takeaway for any NICU nurse is just Be careful with the O2.
Be incredibly careful. You have to titrate those oxygen sats meticulously. It's this constant balancing act between giving enough oxygen for them to survive without giving so much that you damage their retinas for life.
Okay, moving from something we cause to something we have to find. Let's talk about pediatric eye cancer. A retinoblastoma. This is where a really simple assessment can change everything.
It can save a life. And the assessment finding here is non-negotiable. You have to know this. The hallmark sign for retinoblastoma is the white reflex, leukocoria.
Instead of the normal red reflex you see in photos?
Exactly. When you shine a light in the eye, like with an ophthalmoscope, you should see that reddish glow from the light bouncing off the healthy vascular retina. But if you see a whitish, kind of chalky-looking mass in the pupil, that's a tumor.
And that's an emergency.
That is an immediate drop-everything emergency. It's cancer. It can be in both eyes, and it's aggressive. It needs immediate referral, imaging, and often the eye has to be removed enucleated, or they'll need radiation or chemo to save the child's life. The white reflex is a 5-alarm fire.
Got it. Okay, let's shift gears to something that isn't cancer, but is just as time-sensitive in its own way. Strabismus.
Right, what people often call a lazy eye. The actual term for the vision loss is amblyopia.
So what's the mechanism there? Why does one eye drift?
It's all about muscle imbalance. You have 6 extraocular muscles controlling each eye, innervated by cranial nerves 3, 4, and 6. In strabismus, those muscles are out of sync, so the eyes can't align. They can't focus on the same object at the same time.
So the brain is getting 2 different pictures. How does a kid even deal with that?
They can't. So the brain does something clever but dangerous. It just suppresses or turns off the image from the weaker deviating eye. And you see the signs of this, the eye turning in, that's esotropia, or turning out, exotropia. The kid might tilt their head or squint a lot, trying to get a single clear image.
And this is where the high-yield fact about the time window comes in. This is a race against the clock, isn't it?
It's the most important thing to remember about strabismus. Treatment has to happen before that visual pathway matures, which is usually around age 6 or 7. If the brain keeps ignoring the signal from that weaker eye for too long, it literally prunes that connection.
So the pathway just disappears.
It disappears, it atrophies, and the child develops permanent functional blindness in that eye amblyopia, and you can't get it back. So early detection is everything.
How do we screen for it then? What are the key assessments?
We use a couple of standard tests. The cardinal fields of gaze test checks if the eye muscles are moving together smoothly, but the gold standard for screening is the cover-uncover test.
Can you walk us through that?
Sure. You have the child focus on an object, you cover one eye, and you watch the uncovered eye. If that eye has to move or drift to pick up fixation, then you know there's a deviation. It's a simple, powerful test.
Okay, good to know. Let's finish this section with something super common, conjunctivitis or pink eye. For testing purposes, I'm guessing the key is telling bacterial and viral apart.
It's everything, because it completely changes your treatment plan. The key distinction is discharge. Is there gunk or not? Bacterial conjunctivitis is usually just in one eye, and it's characterized by that thick, yellow-green, purulent exudate. That's the stuff that makes their eyelids stick together in the morning.
And viral pink eye.
Viral is the opposite in a few ways. It's super contagious, so it's often in both eyes, and you'll see it run through a family or a classroom. But critically, it does not have that purulent exudate. The discharge is clear, watery. The eyes are just red and inflamed. So gunk means bacterial, watery means viral.
Got it. Okay, so we have the core concepts. Now let's pivot to making those high-stakes decisions. Let's talk about the NCLEX traps, starting with a really serious infection.
Yeah, the biggest trap here is neonatal ocular herpes simplex virus, HSV. This is not your average pink eye. It can cause blindness and spread systemically. The trap is thinking standard antibiotic drops will work.
Because it's a virus.
It's a virus, and it needs a sledgehammer. The treatment is aggressive, immediate, and systemic. We're talking parenteral acyclovir. That's a powerful IV antiviral, plus a topical antiviral ointment. You have to know that specific aggressive regimen.
Okay, good. What about safety for a visually impaired child who's admitted to the hospital? What's the absolute first thing you do?
Immediate physical safety. Before you do anything else, you have to orient the child to the room. The bed is here, the table's right next to it, the bathroom door is 3 steps that way. They need a mental map of their space immediately to prevent falls and injury. Safety always comes first.
Makes sense. Let's talk trauma. A kid comes in with a Shiner periorbital ecchymosis. What's the right way to manage that versus the trap?
The right way is a 2-phase temperature approach. For the first 1 to 2 days, you use ice. Cold compresses. You want to vasoconstrict and minimize that swelling.
And after that?
After about 48 hours, you switch to warm compresses. The heat helps with lymphatic drainage and reabsorption of all that bruised blood. The trap is doing too much. Unless the globe is ruptured, you don't need antibiotics or an eye patch for a simple bruise.
Got it. Okay, so let's lock in the management protocols. Starting with strabismus, the main non-surgical treatment feels a little counterintuitive.
It does, but it's effective. You patch the unaffected eye,
Yeah.
the good eye.
To force the weaker eye to work.
Exactly, it's forced use. You cover the strong eye, which forces the brain to pay attention to the weak, deviating eye. This strengthens that visual pathway and the muscles around it, hopefully before that age 6 deadline.
And if patching doesn't work?
Then you might move on to corrective lenses or even injections of botulinum toxin, Botox, to temporarily relax one of the overactive muscles and restore some balance.
Okay. And for bacterial pink eye, it's antibiotic drops. But you mentioned a major caution point.
Yeah, you have to be very careful with steroids. Never use steroid eye drops unless you are 100% sure it isn't a viral infection, especially herpes. Steroids suppress the local immune response and can make a viral infection explode.
And for kids with more permanent visual impairments, what's our focus in the hospital?
It's all about safety and development. We use tools like Braille or audio materials for education. In the hospital, it means creating a safe, predictable environment. We try to have consistent caregivers to build trust. And we're constantly orienting them. Always speak before you touch them. Describe what you're going to do. Use clock faces to describe where food is on their tray. It's about building a world they can navigate without sight.
Okay, let's do a quick hit summary for this first cluster. Mechanisms.
3 main ones: oxygen toxicity causing ROP, muscle imbalance causing strabismus, and infections, especially at birth, causing all sorts of problems.
Hallmarks.
The white reflex for retinoblastoma, squinting or head tilting for strabismus,
Yeah.
and that thick, purulent exudate for bacterial conjunctivitis.
Critical red flags.
A white reflex, obviously. And that ticking clock, the visual pathway disappearing in untreated strabismus. And remember, no babbling by 7 months is a huge red flag for overall sensory development.
Priority actions.
Patching the good eye, immediate safety orientation in the hospital, and urgent aggressive treatment for things like neonatal HSV.
And the big NCLEX traps to avoid.
Giving antibiotics for viral pink eye and mismanaging oxygen for those super preemies, especially the ones under 1,600 grams.
Perfect. That was a great deep dive on the eyes. Let's move on to our second cluster, auditory and otic health.
All right, on to cluster 2, auditory and otic disorders. So if the eye cluster was about the fragile developing retina, what's the big idea here?
Here, it's all about the vulnerable anatomy of the infant ear. The whole story really boils down to the eustachian tube. In a kid, it's short, it's wide, it's horizontal, and that anatomy is what predisposes them to middle ear infections, otitis media.
And if those infections become chronic, it's a huge threat to hearing, speech, and just overall development. It's a perfect example of anatomy-driving pathology. The eustachian tube is supposed to do 3 things: ventilate, protect, and drain the middle ear. In an adult, it works great because it's long and angled. But in a kid,
It's just not.
not at all. It's proportionally shorter, wider, and much more horizontal. It's a design flaw, basically.
So let's get into the nitty-gritty of otitis media, OM. How does that flawed anatomy actually cause an infection?
Well, because the tube is so short and flat, it's basically a superhighway for pathogens from the back of the throat right into the middle ear.
So any little cold,
Any little URI, or even just milk refluxing from the nasopharynx when a baby is fed lying down,
there's bedded.
it all travels right up that tube. And once that fluid gets into the middle ear,
Yeah.
the tube's bad angle means it can't drain out properly. It just sits there.
Creating a perfect breeding ground for bacteria.
A perfect, warm, dark, sugary culture medium. Yes.
And that structural problem is made worse by environmental factors, right? What are the big ones we need to teach parents about?
Oh yeah, these are highly tested. The number 1 is passive smoke exposure. Secondhand smoke causes inflammation and paralyzes the little cilia in the tubes that are supposed to help clear fluid.
And the feeding position you mentioned.
Absolutely. Don't feed an infant lying flat on their back. That supine position is just asking for reflux right up into the eustachian tube. Propping them up is key.
Okay, so when a kid has a full-blown case of acute OM, what are the classic hallmark symptoms we're looking for?
The parent will almost always tell you the child is frantically tugging or pulling at their ears. It's a classic sign of the intense pressure and pain.
And there's a critical observation for the nurse if that pain suddenly stops, right?
Yes. If the child is screaming in pain and then abruptly calms down and seems better, you need to be suspicious. That often means the tympanic membrane, the eardrum, has just ruptured, the pressure is relieved, but now you have a perforation that needs follow-up.
And what do we see when we look in with an otoscope?
The classic picture of acute OM is a red, bulging, non-mobile tympanic membrane. A healthy eardrum is a nice pearly gray color, and it should move a little bit when we puff air at it. A red, bulging one is screaming infection and pressure.
This all leads directly to the risk of hearing impairment,
Right.
especially with chronic infections.
Right. Chronic OM is the #1 cause of conductive hearing loss in children. And that hearing loss is what ties into our key developmental assessment.
Which is the babbling milestone.
Absolutely. The lack of babbling before 7 months is a huge sensory red flag. An infant should be turning to a parent's voice, cooing, making sounds. If they're not, you have to wonder if they can even hear properly.
And in older kids, it can be mistaken for a behavior problem.
All the time. An older child with undetected hearing loss might be labeled as uncooperative or not listening in school, when the reality is they just can't hear the instructions clearly.
So besides infections, what are some other major causes of hearing loss in kids?
We have to be aware of certain perinatal infections. Meningitis is a big one. It can damage the auditory nerve and often leads to the need for a cochlear implant. Also, remember, ototoxic drugs and congenital rubella can cause profound deaf blindness.
This brings us to the surgical fix for all these chronic ear infections. Tympanostomy tubes, ear tubes. What's the indication?
You put in tubes for kids with recurrent severe middle ear infections, or for a kid who has chronic fluid behind the eardrum otitis media with effusion. That's sticking around for months and starting to affect their speech.
So the tubes act like an artificial eustachian tube.
That's exactly what they do. They create a little hole to relieve the pressure and let any fluid drain out, completely bypassing the kid's dysfunctional natural tube.
Okay, let's switch to the NCLEX traps for this cluster. There are some big ones with otitis media treatment.
Oh, a huge one. The trap is trying to treat a middle ear infection with eardrops. Antibiotic eardrops are completely useless for OM unless the eardrum is already perforated or there are tubes in place.
Because the drops can't get to the infection.
They can't get through the intact eardrum to the middle ear where the infection is. It's just basic physics. The treatment has to be systemic, which means oral antibiotics, usually amoxicillin.
And with amoxicillin, we have to warn parents about the main side effect.
Yes, diarrhea. Amoxicillin is notorious for causing diarrhea in kids. It's an expected side effect, not an allergy, but parents need to know how to manage it to keep the child hydrated. And for comfort, it's acetaminophen for pain. Decongestants don't work.
Got it. What about when tubes are placed? What are the crucial post-op discharge instructions?
The #1 focus is keeping water out of the ears. Those tubes are a direct pathway for pool water, bath water, or whatever to get into the middle ear. So the rules are strict. Quiet activities for a bit, lots of fluids, and absolutely mandatory earplugs for showering, bathing, and especially swimming.
And we need to distinguish acute OM from that other condition, otitis media with effusion, or OME.
Yes, this is a key distinction.
Yeah.
OME is fluid behind the eardrum, but, and this is the important part, without the acute signs of infection. No redness, no bulging, no fever, just fluid.
So no antibiotics.
Absolutely no antibiotics. There's no active bacterial infection to treat. The management for OME is watchful waiting. We might give pain relief if needed, but our main job is ongoing assessment of their hearing, speech, and development over several months to make sure that fluid isn't causing delays.
Okay, that makes sense. Let's do the quick recap for the auditory cluster mechanism.
It all comes down to that unique pediatric eustachian tube. Short, wide, and horizontal. A total failure of design.
Homer.
Tugging at the ear, pain that suddenly gets better, which means a rupture,
Yeah.
and that classic red, bulging, non-mobile eardrum.
Red flags.
The big developmental one,
Yeah.
no babbling by 7 months. And of course, chronic infections that lead to scarring and hearing loss.
Priority actions.
Oral antibiotics, never drops. For acute OM, pain control. And for tubes, you have to protect them from water. No exceptions.
And the NCLEX traps to avoid.
Giving those useless antibiotic drops for OM, failing to monitor development in a kid with OME, and using ineffective decongestants.
Excellent. 2 clusters down, 1 to go. Let's move into our final cluster, upper airway and throat disorders. All right, our final cluster, upper airway and throat disorders. When we're talking about the throat and nose tonsillitis epistaxis, what's the unifying theme here?
Here, the focus shifts to acute risks, and it's all about 3 things: airway stability, hydration status, and This is the most critical part spotting and managing hidden or occult bleeding.
Yeah, these structures are so closely tied to breathing and eating and drinking. The margin for error feels pretty slim.
It really is.
Okay, let's start with a classic, tonsillitis. What are the clinical hallmarks? What does it look like?
You'll see these beefy red inflamed tonsils. They might have white or yellow patches on them, especially if it's strep. The lymph nodes in the neck will be huge and tender. But the biggest thing you'll notice is the child's behavior.
They won't want to swallow.
They won't want to do anything. They'll refuse to eat or drink. They might even be drooling because even swallowing their own saliva is just too painful.
So, given that they have a fever and they're not drinking, what's our absolute #1 nursing priority when they're admitted?
Without a doubt, it's hydration. You have a fever, burning off fluids, and zero intake. That is a recipe for dehydration, fast. So aggressive fluid replacement is priority #1, often with an IV if they can't take anything orally.
This brings up an interesting assessment point that can trick new nurses: the size of the tonsils.
Right. You have to be able to tell what's normal versus what's pathology. And here's the key. It is a completely normal finding for a healthy school-age child to have very large tonsils that look like they're almost touching.
Why is that?
It's just a period of rapid physiological growth of all their lymphoid tissue. So size by itself doesn't mean infection. It's the redness, the exudate, the fever, the drooling, that's pathology.
Good distinction. What about mono, the kissing disease?
Mono can also present with a really nasty sore throat.
Mm-hmm.
And a key piece of patient teaching after any severe throat infection, strep, mono, whatever, is to tell them to throw out their toothbrush.
To prevent reinfection.
Exactly. Get a new one after they've been on antibiotics for a day or so, or once they're feeling better, to avoid recolonizing themselves with the same germs.
Okay, let's move to epistaxis. Nosebleeds. Pretty common, but the management is very specific. What causes them, usually?
Most of the time, it's just local trauma nose picking or inflammation from a cold, maybe some dry air. The bleeding comes from a fragile little network of blood vessels in the front part of the septum.
So, for an active nosebleed, what is the priority nursing action? This is all about positioning, isn't it?
100%.
Yeah.
You have to control the bleeding and prevent aspiration at the same time. The child must sit up and lean forward, not back. Forward.
Okay, sit up, lean forward.
Then what? Then you, or the parent, pinch the soft, fleshy part of the nose right below the nasal bone, and you hold that pressure continuously for a full 10 minutes by the clock. You can also put some ice on the bridge of the nose to help vasoconstrict.
And what's the big red flag? The thing you must not do.
You absolutely do not let them lean their head back or lie down.
And the rationale for that is critical.
It's so critical. When you tilt the head back, all that blood just runs down the throat into the stomach.
Yeah.
Blood is full of iron, which is a huge gastric irritant. So they swallow enough blood, they get nauseous, they vomit, and that violent vomiting can dislodge any clot that was starting to form. It's a dangerous cycle.
That makes perfect sense. Okay, now let's focus on the post-op care after a tonsillectomy. This is huge. If you can only remember one post-op assessment, what is it?
Frequent swallowing. That is the #1 sign of a hidden post-operative bleed. A child, especially a sleepy one, might not spit out blood. They'll just keep swallowing it, drip by drip.
Are there other subtle signs?
Yes, increasing restlessness, pallor, and then later, the vital signs will start to change tachycardia first, then hypotension. But that constant little swallow is your earliest, most reliable clue.
And the timing of the bleed risk is tricky too, right? It's not just right after surgery.
That's a massive NCLEX trap. The risk is biphasic. You have the immediate risk in the first 24 hours from the surgery itself. But then there's a second, often more dangerous risk about 7 to 10 days later.
Why then?
That's when the scab, the fibrin clot over the surgical site, naturally falls off. And sometimes it can take a little piece of a blood vessel with it. Parents have to be taught to watch for bleeding during both of those periods.
What about positioning right after the surgery?
Positioning is all about preventing aspiration. Until the child is fully awake, you want them on their abdomen prone or on their side. That position lets any blood or secretions drain out of their mouth instead of down into their lungs.
Got it. And for epistaxis, the trap is just doing that positioning wrong.
It's getting it backwards.
Yeah.
Sit up, tilt forward, pinch. Tilting back is unsafe and wrong.
Okay, let's lock in the management for this cluster. Post-tonsillectomy, what are we focused on?
It's mostly non-form. We're pushing fluids, but the right kind. Crushed ice, popsicles, and importantly, no red-colored liquids, because you don't want to confuse it with blood.
And pain control. What's the medication of choice?
Acetaminophen, Tylenol. We usually avoid NSAIDs like ibuprofen at first because they can interfere with platelet aggregation and increase the bleeding risk. And we also avoid irritating foods. No citrus juice, no chips, nothing scratchy for at least a week or so.
And for epistaxis, management is almost all non-farm.
Correct. It's that positioning forward, pinching, ice. And then teaching the child not to pick or blow their nose forcefully for a few days to let that clot really set up.
Okay, final quick recap for the airway cluster.
Mechanism?
Inflammation, infection, or local trauma to the nose or throat.
Hallmarks.
Drooling and dehydration from a sore throat, those beefy red tonsils, and any uncontrolled bleeding.
Red flags.
The #1 post-op red flag is frequent swallowing. It means bleeding until proven otherwise.
Priority actions.
Aggressive hydration and controlling any bleeding with the correct positioning, sitting up and leaning forward.
And the NCLEX traps to avoid. Missing the subtle signs of a post-tonsillectomy hemorrhage and that critical mistake of tilting a child's head back during a nosebleed.
Fantastic. That's a really solid breakdown of all 3 clusters.
Yeah, we've covered a lot of ground from the eyes down to the throat. And I think the big thing that connects all of it really is this idea of developmental vulnerability.
Can you expand on that?
Well, think about it. The short, flat eustachian tube causing ear infections, the immature retinal blood vessels in ROP, the fact that babies have to breathe through their noses, that time-sensitive window for the visual pathway to develop in strabismus. It's all about how a child's unique anatomy and development creates specific clinical risks.
And understanding that is what drives our reasoning. It's not just memorizing facts. It's knowing why these things happen in kids specifically.
Exactly. And that's how you get good at this.
Mm-hmm.
You translate what you see into immediate action. You see a white reflex, you think cancer, you act. You notice a baby isn't babbling, you think hearing loss, you act. You see frequent swallowing after a tonsillectomy.
You think hemorrhage and you act. That translation from observation to urgent action. That's what expert clinical reasoning is all about.
You have the rationale now. You have the defenses against the most common traps. Just keep coming back to those 5 pillars for any disorder you study.
So now that you can confidently tell the difference between something benign, like those big but healthy tonsils in a school-age kid, and a huge red flag like the white reflex, here's a final thought I want you to chew on. Imagine you're admitting a 6-month-old for dehydration. You know that hearing loss can be linked to other developmental delays. So which specific sensory milestone, is it cooing, babbling, or visual tracking? Which one will you make it a priority to assess during your initial exam to make sure you catch the earliest possible sign of a sensory development problem?
It's a great question to think through. And we really encourage you to take this cluster mechanism, hallmarks, traps, priority actions, and apply it to everything you study. You are definitely more shored up on your pediatric ENT knowledge now.
That's all for this deep dive. We'll catch you next time.